Hello and welcome everybody. Thank you so much for joining CareerCert and UT Southwestern for our webinar today. I'm your host for the webinar, Danielle. At CareerCert, we are focused on providing emergency and healthcare professionals with the training they need to best protect and care for those in our community. That's why we're so grateful to be able to partner with UT Southwestern today in order to provide you with this webinar. And we are so grateful for the opportunity to connect with each of you. It's my pleasure to introduce you to our presenters for this webinar. Gil Salazar, Paul Rosenberg, Virginia Smith, and Megan Dahmer. Dr. Gil Salazar Dr. Gil Salazar is an associate professor of emergency medicine at UT Southwestern. He serves as the medical director of EMS education and oversees both initial and continuing education of area EMS professionals. He practices clinically at Parkland Hospital Emergency Department. Dr. Salazar is duly board certified in emergency medicine and EMS and serves as core faculty for the emergency medicine residency and the EMS fellowship programs of UT Southwestern Medical Center. He is the creator of Campus Emergency Preparedness and Survival Training. His main goal is to improve the quality of education in the management of natural and human-made disasters. Megan Dahmer completed her paramedic training at UT Southwestern in 2015 and is currently licensed through the Texas Department of Health as a paramedic. She then pursued a bachelor's in nursing at Texas A&M Commerce, graduating in 2016. Megan currently works in the ER at Parkland Hospital as an RN. Megan and her husband are the proud parents of 2 young boys. Dr. Paul Rosenberg has over 30 years of EMS experience, with over 20 years of adult education instruction. He has performed ground and flight paramedic duties and leadership in town administration during his service. He has served as a faculty member and assistant program director for UT Southwestern. Currently, Dr. Rosenberger is the associate director of the EMS continuing education program at UT Southwestern and an adjunct faculty member of the Emergency Services Administration BAAS program at the University North Texas, Dallas. He is also the co-chair for the National EMS Education Standards Developmental Revision Team. Virginia Smith is a licensed paramedic for Cypress Creek EMS in Spring, Texas, which utilizes aggressive emergency protocols, including whole blood in the field. She is currently completing training to serve as the in-charge paramedic position in ambulance teams responding to 911 calls. Virginia received her bachelor's in biology from Texas A&M and her master's in biomedical sciences from University of Incarnate World School of Osteopathic Medicine. Virginia is a medical school applicant and hopes to be accepted and start medical school fall of 2021. Virginia's training has included medical care in wilderness settings and rural poverty in Latin America, where medical services are limited. And now I will go ahead and turn the time over to our presenters for today.
Okay, welcome to class today. This is Paul Rosenberger, and our topic today is when EMS encounters this alarming and precarious infection. And so for the moment, I'm just going to leave you wondering what that particular infection is, and we're going to cover the objectives for today. So after attending the lesson today, we hope that the learner will be able to describe the proper assessment of a patient complaining of angina. We also want you to be able to consider at least 5 potential sources of angina. So we'll have a section on differential diagnosis. We want you to be able to evaluate the patient's airway, ensure that the patient has adequate ventilation and oxygenation, and also to select proper airway techniques when it comes to managing a difficult airway, and also make a connection between sepsis and angina. So sounds like some pretty crazy objectives, but we're going to put all the pieces to the puzzle together for you. Thank you so much.
Okay, welcome everybody to our second offering. We're very grateful to CareerCert for the opportunity to bring you some information which we hope you're going to learn a thing or two about. I'm very grateful to our presenters today, my co-presenters, Megan, Virginia, and Paul. They're handpicked by our team for their experience and their ability to put a tough clinical picture together. So I hope you learn a thing or two. This is an open discussion. We welcome your comments during and after. Want you to give us a little bit of feedback and see what you think we did well, the things we could improve upon, and future offerings. We are always delighted to bring you the best and the greatest as best as we possibly can. So let's begin with the case presentation. To give you a little bit of heads up, during the presentation, we're going to be firing off some polls. Please go ahead and just tell us what you think. We're not going to quiz you. We're not going to be picking on you at all. So we just want to see what you think, what your practices are, and hopefully by the time we're done, we're going to all learn a thing or two. All right. So let's begin with the case presentation. The call came in through dispatch as a female patient with a chief complaint of chest pain. Upon arrival, the medics, consisting of 2 paramedics, assessed a 64-year-old woman, history of diabetes and also high cholesterol. She reported 1 day of worsening chest pain. Pretty interesting story. The patient had actually tried to contact her primary care doctor a few hours before. She actually had an appointment coming up, but she noticed that she was just not getting any better, and ultimately her husband decided to call 911. Next slide, please. The medics reported and documented a little bit more history. They did a phenomenal job of documenting an ample history. Patient has no allergies. Of note, she takes aspirin 81 milligrams, takes a statin for high cholesterol, carvedilol, a beta blocker at 25 milligrams, takes an iron supplement daily for some anemia she had some time back, and also uses insulin. Some type 2 diabetics and whose pancreas is burnt out, they can use insulin as well, sometimes in addition to oral medications, but this particular patient used insulin. As we mentioned, medical history positive for diabetes, high cholesterol, and some hypertension. She takes the carvedilol for that. Please make a note of that as we go throughout the case. They documented a last oral intake, and that is something that I encourage our medics to do, and especially when it comes to potential airway issues, toxicities. Knowing a last oral intake is really important. They got a bit of a better history of the chest pain, definitely worsening with some associated difficulty breathing, which reported to the medics as inability to lay down, not really exertional in nature, just some heaviness, never experienced it before, despite her issues. She's had some issues with her weight, and an associated cough, which she reported as being more like inability to clear her throat. So not productive, not dry. So let me pick on Virginia a little bit, one of my proteges. And Virginia, walk us through your differential diagnosis for this patient. We'll show the next slide as well.
Absolutely. Well, whenever I see chest pain like this, I'm thinking a cardiac cause. I don't know exactly what it is at this point. I'll need some more information, but that's my go-to thought process with chest pain described like this, heaviness. And so I'd immediately want some vital signs and a 12-lead ECG.
Fantastic. The next slide will show you some other differential diagnoses that we put together for you. Let's move on to the patient assessment for the time being. Let's go back to the slide on the case presentation. Thank you. We noticed the patient was afebrile, a normal temperature. Heart rate was at 62 the time of assessment, very hypertensive. The patient later on reported this was not far from her baseline. She was having some trouble controlling her blood pressure and had recently been upgraded to the carvedilol for better control. The documented respiratory rate on the ePCR was 20 with an O2 saturation of 92% on room air. And the patient's entitled CO2, this high functioning system The does get entitled CO2s in the field. On his initial assessment was 38. And I really commend him for that because that comes in very, very useful later on in the case. And a glucose of 129. On physical exam, some of the notables that we pulled, she was documented as being obese. She was oriented to person, time, and circumstances. Her pupils were equal, round and reactive. No documentation of the airway otherwise. Lungs were clear to auscultation bilaterally. Heart sounds are normal. No jugular venous distension was noted on the neck, and then no leg swelling. Let's move on to the differential diagnosis. While some of you make notes and put it together, I always teach my students and my medics to always kind of look at two different issues: the critical causes and more the kind of emergent causes. Definitely STEMI, aortic dissections, pulmonary embolus, tamponade, and Boerhaave syndrome is something that we don't see every day, but definitely should be aware of because it's life-threatening. It's essentially an inflammatory process coming into the mediastinum in the central portion of the chest from a ruptured esophagus. Happens a lot with people who've had bad retching, bad vomiting. Can happen in alcoholics, and also tension and pneumothorax is the other one. Other emergent causes, always consider pericarditis, myocarditis, especially in this era of COVID. Myocarditis is a cause of chest pain and involves inflammation of the muscle of the heart. Consider simple closed pneumothorax. Mediastinitis is inflammation of all the organs there, really between the lungs and the chest. Also consider some atypical causes of chest pain, such as referred pain from a cholecystitis in the gallbladder and pancreatitis. Okay. So Virginia mentioned that she wanted to get a 12-lead ECG, and the medics did just that. I'm gonna pick on Megan a little bit and see what you think of this EKG. This was the first one obtained by EMS.
So just looking at it, quick glance, you know, we don't always have a lot of time to just sit and count everything out, but quick glance, looks like the rate and rhythm are okay. It doesn't look too fast or too slow. I don't see any marked ST elevation or depression in any of the leads that have me super concerned. And I don't see really any diffuse ST elevation anywhere that would, you mentioned pericarditis and the differential diagnosis. So I don't see any of that would alarm me thinking something like that. The T wave seems a little bit long, but other than that, nothing is super alarming here.
Yeah, that's definitely a good call. I think the rate matches this patient, and you gotta remember she is beta blocked. And so in and of itself, it will not cause ECG abnormalities, but certainly when I look at any patient in the field and they're beta blocked, I gotta take that with a grain of salt and think, what is their heart rate? What would their heart rate otherwise be? Of note, let's point out she does have some flattening, even close to inversions in one and AVL, those lateral leads. So in this patient with hyperlipidemia, high cholesterol, diabetes, and hypertension, they definitely acute coronary syndrome, non-ST segment elevation, MI is in the differential diagnosis as well. Megan, you made wonderful mention of pericarditis, and that's something that can sneak bias because they can have very diffuse ST segment elevations in that. PR depression, I don't see any of that, so definitely a good call on that one. Then I'm wondering about AVR, AVL, AVF, and on lead 2, I'm wondering if that could have been a little bit of an artifact at the time of obtaining the EKG. I don't think that it's real. It could be, but all in all, I think it's a fairly unremarkable EKG, save for those ST segment flattenings, the T-wave inversions. So Megan, you made a good call on the EKG. What do you do with this patient? We got a good differential going. You know kind of what we're dealing with. What do you do with this patient?
So as Virginia already said, we already got this 12 lead, and given back on her blood pressure, it was 190s over, I can't remember the diastolic, but, you know, I think she could handle a nitro and see if that maybe could relieve her chest pain, because, you know, we're going with cardiac causes of these chest pain. Aspirin always 324. Her O2 sat was 92%. You know, that's a little lower on the low side, and just give her maybe some nasal cannula around like 2-3 liters, see what she bumps up to and how she tolerates it. And then, you know, we would consider pain meds.
Yeah, definitely. This patient was going down the chest pain route. I think there was sufficient evidence to keep going in the acute coronary syndrome route. 3 doses of nitroglycerin, interestingly, didn't really help this patient. Fully agree with the aspirin, got that line started, and I'm very glad to see that we're very aggressive right off the bat with the fentanyl. I think 50 mics for this patient is a little underdosed, but in their clinical protocols and their guidelines, it calls for around this amount on their first go around. It's an agency with a short transport time, so I think the decision to give her some fentanyl 50 is perfectly well. Virginia, have you ever heard of any systems? Perhaps some of our friends in the conference can have protocols for hypertension management in the field. Ever been aware of any systems that use antihypertensives?
Yes, there are systems. It really depends on what the medical director is comfortable with and what they are comfortable with putting into their protocols. We have a little bit more aggressive for fentanyl if we thought it was necessary, especially if she is obese. Then she probably weighs a little bit more than 50 mics. And there's other tools at our disposal for hypertension.
Excellent. Yeah, some systems, I'm very curious to hear in the chat and then feedback if there's any systems that do something like hydralazine for this very hypertensive patient with a suspected cardiac etiology. So I think the medics are doing a remarkable job with this patient, following all their clinical guidelines. And, you know, we wouldn't be discussing this case if there weren't opportunities for learning. So let's move on to the next slide and see how the patient is doing. We know the patient has worsening difficulty breathing en route. At this point, we're in the back of the box. She's reported as acting restless, anxious, continuously trying to sit up, saying that she's trying to catch her breath a little bit and that there's a lot of heaviness. With the nasal cannula, the O2 saturation went up a little bit initially, but the medics ultimately decided to start some CPAP at 10, which I think was the right decision. Repeated some vitals, temperature really maybe a little bit elevated from the first one, but normal still. Notice the tachycardia this time around closer to 100, still hypertensive. Definitely more tachypnic, and then the O2 saturations were fluctuating between 88 and 92%, with intermittent desaturations down to the low 80s. And take a peek at this entitled CO2 of 52, and we're talking literally a few minutes into the transport. So Megan, I want to, and Virginia as well, what do y'all think at this point? I want to hear your thoughts. Virginia, let's start with you. Is this kind of the path you would have taken? Anything you would have done different?
Well, the O2 saturations with the desatting, that is a cause for concern. I definitely want to monitor the patient, look if she's getting tired, especially with the CPAP, if she's like struggling to fight it, deciding that she doesn't want to fight it. Also, like, look at her mentation, like see if she's out of it at any point, confused. But at this point, I definitely watch her closely and reevaluate, but I'm still gonna watch her, especially because you said that they have a short transport. And so I am gonna make sure I'm going emergent traffic. I am gonna let the hospital know that this patient is very sick, but I think I'm just gonna monitor her at this point and just recheck everything until we get to the hospital.
Sounds good. I'm gonna be watching here the poll very carefully. It sounds, Virginia, like you want to be fairly conservative with this one. Megan, what do you think? Are you on the same camp?
Actually, I would agree with that if I felt like if she didn't progress so quickly, or I guess degress so quickly. You know, her O2 sets are dropping no matter what we're trying, and she just doesn't seem to be responding well to our interventions. You know, and based on our protocol, I would, you know, call and make sure I could, you know, do an RSI, and get her intubated as soon as possible, because I feel like we're probably losing our airway, and I think that I'm seeing a ventilation problem if she's starting to get confused and she's not mentating well. And then because of her body habitus, you had mentioned she was obese. I don't know that I would even want to mess around looking for a regular ET tube. I'd probably just throw in a king tube.
Gotcha. It sounds like one of you wants to be fairly conservative, the other one more aggressive. I like it. I'm seeing a little bit on the chat right now that, yeah, the nitroglycerin wasn't helping, so it leads to want to think it was probably not cardiac in nature. I agree with you. Definitely want to look for other causes. Looks like in the poll results, the majority of you want to monitor the end-tidal CO2 only. Some of you want to start BVM, and a couple of you, about 5% of you, want to throw in some advanced airways or even a supraglottic device. So, all right. Yeah, that sounds good. I think the medics at this point, we're in a position where due to body habitus, the patient's condition, I think they felt the patient was being adequately ventilated with the CPAP at that point, and with the short transport time, I think they chose to watch this a little bit. So I think, Virginia, they agree with you. Thank you for your comments on the poll. Keep them coming. So at this point, we are now at the hospital. And we know that the patient, as soon as they rolled in, an initial assessment was done and was intubated shortly upon arrival. A fiber optic scope was done. This is a picture of what the neck looked like. You notice there was a little bit of redness in that area. The patient was, the airway was not an easy one. And as I mentioned, a fiber optic was done. So make a note of this finding. We did document in the EPCR initially that no JVD was finding, but no mentions of this discoloration were done. And you can see it tracks basically from the sternal notch all the way up into the mandible. And a further workup was done, including a cardiac workup. With somebody who is deteriorating this quickly, one of the things that entered the differential diagnosis was more of a kind of an upper airway, kind of soft tissue deal. So let's go over to the next picture and see what we find. Some images started coming in for the patient. One of the things I want to point out is you can see right under the mandible, you start seeing some soft tissue air, and we're going to circle it right there using the cursor. That's definitely not normal. You can appreciate that the patient's body habitus, she's got significant soft tissue at baseline, but you see there's quite a bit of fullness there under the mandible, and that's just from the lateral film that we obtained. On your right, on figure B, we see a cross section that's from a CAT scan. And so I want to kind of orient you a little bit. This is a cross section of the patient's head, as if you're looking at the patient straight on. And so Paul, let's point out really the cross section for the skull, for the cranium up at the top. Okay, and as you go down, we're going to see the sides of the mandible. Those are cross sections of the mandible right there in the left, and that's actually the patient's left, and then the right on the opposite side. You can see some of the patient's teeth and some of the crowns or other dental procedures she had. And you notice there on the patient's right side. So when you're looking at this one, the patient's right is there on your left. You can see that there's air, there is material there within the soft tissue. That's very, very abnormal in a patient that's already has a difficult body habitus, a very tough airway more than likely. And now you got all this soft tissue swelling and air. That's very abnormal. That's pointing towards an infection. And pretty soon after that, that's when the diagnosis is made of what's called Ludwig's angina, Ludwig'(S), angina or angina. Let's move over to the next picture.
Before we move,
Go ahead.
Dr. Salazar, if based on the last picture with the erythema on the neck and the throat, and then the CT, you know, we don't have CTs in the back of the ambulance. What could you be telling me about this patient as more of their assessment? Like, what am I looking for? And in their mouth, do I see any broken teeth? Do I see any sublingual floor elevation? What more assessment could I be looking for to be prepared for an infection like this?
Yeah, absolutely. You know, it's something we don't see every day. And as I mentioned before, the medics did document that they looked at her neck. I'm wondering, you know, we don't really undress patients all that much in the field unless we absolutely have to. So I'm wondering, you know, does she have enough, a lot of clothing in place that could have prevented us from doing that? Now, if once you put the patients in gowns, it's a lot easier to appreciate just how much discoloration that there is. And so if I'm looking at this patient in the field, I'm going to be wondering, you know, is this soft tissue swelling because of the mandible? Is it more along the trachea? And you got to start thinking of things like epiglottitis. Patients with epiglottitis don't have external findings like this. Once you have external findings, such as the one that you see, Ludwig's angina enters your differential diagnosis. I'm going to look very quickly here at some of the comments that we had.
And Dr. Salazar, you also talked about some of the symptoms being difficulty swallowing or painful swallowing or drooling. Can you talk a little bit about that?
Absolutely. She, at this point, you've got to start kind of playing Monday morning quarterback, and kind of hindsight, you start wondering about some of her complaints that she had, such as difficulty catching her breath or becoming more restless in the back of the ambulance. Somebody in the comment made a very wise observation. We started kind of messing around with her a little bit. And so I'm wondering if at home she was very, very comfortable positioning herself and as comfortably as she could, and things were looking okay. The moment we transport her and kind of mess with her positioning, I'm wondering if she started decompensating partially. Also, some of the things to look at in this very specific patient, she did have elevation of the floor of the mouth, specifically under her tongue, sublingual floor elevation. That's going to be one of the most common findings. That area should be at the very least nice and flat. If you start seeing any doming, that's very concerning. Now, the tongue can look remarkably normal, but when you start seeing that doming of the sublingual floor space, that's pretty concerning. Drooling can take place. The majority of these people, though, are going to complain of a lot of discomfort with swallowing, etc. They might be spitting into your MS's bag, but it's going to be just a lot of fullness, a lot of discomfort, trouble laying down, etc. So very, very, very tough case for sure. Now,
so
one of the biggest implications.
Sorry, go ahead.
Go ahead, Virginia. Go ahead.
How do we tell the difference between if she does have this kind of painful swallowing? We could consider something like even just strep or epiglottitis or croup or something like that. How do we tell the difference with Ludwig's angina and some of these other kind of throat, mouth diseases?
Yeah, the hallmark of of this type of infection is the amount of soft tissue involvement under the mandible. You know, most streptococcal infections, viral infections, even epiglottitis, croup are going to have very minimal to none external findings. But this patient, certainly a kind of quick look now that she's undressed in a calmer environment, showed a pretty remarkable fullness of the neck, even discoloration. So the moment you see any submandibular involvement and fullness, you really want to start thinking about a deep space infection of the soft tissues like Ludwig's angina. The one of the biggest concerns.
What did it feel like when you touched the like submandibular area right here? Was it hot? Was there crepitus? Like what, if you like continued your findings to kind of palpate that a little bit, what does it present as?
Remarkably tender, very, very tender, not hard, although you can have some induration of the skin and the soft tissue. It's just very, very tender. They might not have that degree of discoloration, but that area can be very full and very tender, sometimes very indurated. This patient had a pretty remarkable set of findings all throughout. So the moment you see anything kind of in that area of the neck, Ludwig's angina has got to come into the differential. Not surprisingly, the biggest portion, the biggest problem with these patients in the emergency setting by EMS and in the emergency department is going to be the airway. So I want to kind of show you the images, kind of some cross sections here. That's the patient's MRI. Really what you're seeing is basically kind of slicing the patient in half. Want to point, you see the spine there in the back, and you got all levels, so from the cervical spine all the way down into her lumbar spine. You see the sternum right up front. You see a cross section of the sternum. You see all the mediastinal organs. You see portions of the aorta behind it. You see portions of the heart in there. And I want to point out the area there that's black, where your cursor is going. That's all trachea right there. Black is air on these images. And I want to point out that right above where you see the trachea, there's that arrow. You see quite a bit of kind of soft tissue widening, for lack of a better word. That's very abnormal. That area should be nice and tight. You see quite a bit of swelling. Also on the image there to the right, you see that arrow pointing there. That's all that submandibular tissue that I showed you earlier, and that's all in the neck right there. You can see just how much abscess, fluid, inflammation there is there on her neck, and you can see just how low all of that inflammation goes, all the way up into your sternal notch, as you can appreciate on the MRI. Now, I want to point out something very interesting here as well. That second arrow, the one where your cursor is right there, it shows you there's air really right behind the esophagus and all of those tissues there. There's not supposed to be any air behind any of that. No air in the mediastinum. That's clear-cut mediastinitis. So what happened to this patient is all that swelling, all that bacteria, some of these can be gas-causing bacteria, started kind of filling up not just the neck and the mandible with air, fluid, and abscess, but also kind of affecting the mediastinal structure. So guess what you have on your hands in terms of symptoms? Chest pain, dyspnea, reporting she was having trouble like catching her breath, and sometimes like passing saliva, etc. Just a lot of chest symptoms. Any comments or questions about any of those, Virginia or Megan?
That makes sense. Go ahead.
Okay, I was just going to say that the fullness feeling could explain, you know, like you were saying, the chest pain, and then the difficulty swallowing for sure, and then maybe the positional comfort, like if she can't, with all of that swelling going on, not being able to lay down, and
Excellent. Absolutely. Another comment came in asking if the patient had tonsils. The patient did have her tonsils. In a little bit, we'll discuss some of the pathophysiology of Ludwig's angina. Another question that came in is, as an EMT, what else can I be doing to assist my medic in terms of airway, etc.? I think one of the biggest things for a basic to do in this situation is assist the patient in finding the most comfortable position. Just like we teach in things like epiglottitis, for example, this also goes a long way. We'll discuss some airway management here shortly, but one of the things that I learned from this case is positioning. It's all about positioning a lot of times. This patient was very comfortable at home. All of a sudden, we changed her positioning for various reasons and for transport, and she became worse. Let's look at a couple more pictures here, and just to show you the relation there to the patient's airway and just how precarious this infection is. You see the trachea there. You see that ring around, this kind of the black there. Those are tracheal rings. That's cartilage. That shows really well on this image. And you see this is very high up in the neck. You start seeing how a lot of this inflammation, all that infection is kind of starting to surround the trachea. So I am not surprised. So not only was this patient's positioning a problem, but also now you're having some involvement around the trachea. You notice there's that area just to the right of the trachea there that looks really, really white. On the opposite side right there, you see quite a bit of uptake there. All of that stuff could be abscess, inflammatory fluid, etc. So very, very precarious, very sick patient. And the last image I will show you, this is another cross section there. You can see just the sheer amount of abscess that this patient exhibits just in that area of the neck right there. I think hopefully I made it the case of just how extensive and how dangerous these infections have made. Virginia, knowing what you know now, do you think the right answer was still to monitor the patient, or would you have gone more aggressively?
I think I would have gone more aggressively.
Megan, are you gonna stick to your guns or be more conservative?
I definitely stick to my guns, hoping that you know, we weren't too late in getting a tube down with all of the sublingual swelling and, you know, it displacing the tongue. Hopefully I was able to get past that. And, you know, if I wasn't, you know, would we be considering any other advanced airways like a crike, and what kind of complications could come in with that, with the swelling that we're seeing on the CT and what you're telling us about, and her body habitus, would I even be able to find that if needed? So I definitely would have stuck with my being a little bit more aggressive.
Yeah, definitely. I think the decision to intubate this patient would not have been at all ill-advised. I will say this was a very difficult airway to begin with, and you know, in a less controlled environment, this might present a serious problem. So I think the medics did a nice job of monitoring the patient. If they had to go and be more aggressive about it, we're going to discuss some very specific pointers specific to that. Let's go to the next slide, Paul. Let's discuss very briefly some of the pathophysiology of Ludwig's angina. I want to point out that really under your tongue, you have quite a bit of soft tissue and actually a big potential space where infections can really seed and grow, reproduce, and really get a lot larger. You have glands, you have fat tissue, you have muscle, and a lot of potential space. So some of the common, if we can go to the next slide really briefly, Paul, then we'll come back to the picture. This submental space and the submandibular space can be affected quite a bit. And this is fairly, you're going to see it more commonly in folks with immunosuppression, such as diabetes, HIV is another one. Some patients on chemotherapy and radiation, for example. Some patients who have had neck radiation for cancer, and sometimes preceded by dental infections, dental procedures. So when you encounter this in the field, one of the main questions is assessing the patient's risk factors to have this. Have you had any procedures recently to your teeth, any infections, and having I've seen patients who go out of the country for less expensive dental procedures who come back and have this as well. The scary thing is that it can spread into your mediastinum, causing massive issues in terms of infection. They need broad spectrum antibiotics for a certain number of days. A lot of them spend time in the ICU, and the majority of them wind up needing surgical procedures under their neck and washouts to get these taken care of. Some of the symptoms we discussed can be something from just neck pain, discomfort, fullness, sore throat. And don't forget that these patients, when there's mediastinal involvement, can present with some cough, difficulty clearing their secretions, sometimes drooling, sometimes just chest pain. If you start seeing any of those, start thinking mediastinitis too. There's nothing specific to do in the field specific to mediastinitis, but just remember, if they have inflammation in the mediastinum, there's no reason not to have high degree of concern for involvement of your myocardium later on, arrhythmias, etc. I think the most important point is that intubation and advanced airway management for these patients can be very, very difficult. Let's go back 2 slides to the picture, Paul. You can see on the right that the tongue can be displaced toward the top, toward the back, because of all of this infection. So you can imagine trying to intubate a patient like this. Not only is her body habitus a very prohibitive item, but now you also have significance of lingual floor elevation, and that tongue is displaced upwards and to the back. So you can imagine trying to do a direct or even a video laryngoscopy in the back of an ambulance or on scene for these patients. You may have a really, really, really tough time with them. In a second, I really want to discuss some of the airway management pearls for this patient. I'm going to just look at the chat right quick. Any respiratory issues? Could be an allergic reaction. Thoughts of potential medication for tongue swelling. Yeah, right along what we were talking about. The tongue may not actually be inflamed or actually even involved in Ludwig's angina. It's more the displacement. I have seen tongues that are larger than usual, but really no medications that we can give in the field really help, even the antihistamines, because it's all inflammatory fluid, even abscess and infection. Definitely a good thought. Any questions, Virginia or Megan?
What would you be able to see if there was a dental infection? Would it just be poor tooth hygiene or a recent dental procedure? Would that be a history question, or would that be something that you would be able to see some sort of infection like in the teeth?
Phenomenal point. One of the things that I'm teaching, I've taught for many years now at the initial level, is for any patient, no matter what the chief complaint is, and this is a classic case, is doing a fairly basic airway assessment, because you may be dealing with something that's an airway emergency. You may not even realize it just yet. Some of these patients, things that I have found specific to Ludwig's angina, we mentioned before dental procedures, some of the kind of giveaways. They may have some gauze left over from their surgery. Sometimes things like surgical gauze can be kind of left in place for a day or two to kind of soak up any extra fluid. When I see that, and the setting of kind of neck pain and discomfort, I have Ludwig's angina until proven otherwise. Definitely poor dentition can be a significant issue. Sometimes patients may have some gum recession, even swelling. That's how a lot of these begin, is with infections of your gums, periodontal disease. And so in the majority of these cases, we wind up involving our oral surgery colleagues because they did need a dental procedure as well.
I was going to ask, in my experience, it usually the swelling starts unilateral and then will end up being bilateral. Is that the case most of the time? Because this presentation makes it sound like it started lower, and so I'm wondering if it was unilateral the entire time. And then a second part of my question is, you know, the concern about this being an allergic reaction versus the Ludwig's angina. You know, the other things we could be looking for is their lung sound still clear? Would we be hearing anything like stridor or hoarseness when they breathe? What are some other things that we could be looking at to rule out an allergic reaction versus the Ludwig's, and then the unilateral versus bilateral?
Outstanding. These infections can begin in the unilateral space. I find that, you know, these tend to be generally at the base of one of the molars, either in the maxilla, but most commonly the mandible. So they tend to begin on one side. One of the crazier things is a lot of these patients will actually seek dental care, even some medical care. They'll be started on antibiotics for a dental infection, or they may even have antibiotics from prior disease processes and infections, so they'll self-dose. And so they might actually be walking around with very slowly progressive Ludwig's angina that may just show on one side, but sooner or later, trust me, you're going to have involvement of that entire sublingual space. So yeah, so be on the lookout for, if you hear antibiotics like penicillin, Augmentin, some of these penicillins that we use for dental infections, and this is in your differential, I think you have a winner. In terms of allergic reaction, I think that's a fantastic point. You know, anaphylaxis can present with significant soft tissue findings on the oropharynx, and I've actually seen this treated as an anaphylaxis. There would be absolutely nothing wrong with treating initially like an anaphylaxis. You're not harming anything. You're not really delaying any care. You're still conscious of a potential airway emergency on your hands. So definitely nothing wrong with going in that route. So this education is to give you just another tool in your tool bag for you to consider. Let's move on over to our airway discussion very briefly for the next 3 to 4 minutes, then I want to open it up for further questions. Every system has their own clinical guidelines and protocols for airway. When it comes to Ludwig's angina, I look at it in this light. I think if you want to go the rapid sequence intubation route with these patients and they've failed non-invasive ventilation, I think preparation, positioning, and pre-oxygenation are going to be of paramount importance. If they're awake and talking to you, I think you have more than plenty of time to prepare these patients adequately. I think the thing that's going to help you the most in terms of preparation, your equipment, if you use video laryngoscopy, I've found that to be superior in these difficult airways. Although I grew up with direct laryngoscopy, the angle that you have to take to intubate these patients is a very, very, very tricky aspect, and you can only overcome it with some of the hyperangulated blades that you can see with video laryngoscopy. Not every system has the hyperangulated blades, but you wind up needing a much better, more aggressive angle to intubate these patients. When it comes to positioning, we preach quite a bit bed up, head up intubation. You see that this patient already has a large body habitus, a good amount of soft tissue at baseline on her neck, and now adding Ludwig's angina in there. The moment you lay this patient down, so that tongue is already displaced backwards, all that soft tissue is already pressing. The moment you lay her down, you're putting even more pressure on your soft tissue, on your trachea, etc., making intubation quite a bit more tricky. So sitting the patient up at least 30 degrees is pretty helpful. You want to have your most experienced operator And while we discuss this, I want to kind of check on the poll here and kind of want to hear what your system allows in terms of advanced airways. And I want to hear especially what you might use for this patient. So bed up, head up positioning would be very, very adequate. If I'm gonna go ahead and put an ET tube, my bougie is gonna be leading the way. I'm gonna use that as my stylet. That way, if I get a very quick view of the cords or even just my epiglottis and I can pass my bougie through, I can at least get something in there, because you never know how tight that space is gonna be, and it might be tricky to get anything in there after the first try. So bed up, head up. I'm gonna have my bougie ready, loaded into my tube, and I'm gonna pre-oxygenate these patients very aggressively. Like this patient, they may have some reserve left over, but that's not always the case. You already saw that she was gonna need some supplemental oxygen to begin with, so her reserve was fairly low. I'm gonna aggressively pre-oxygenate these patients with nasal cannula. I'm gonna bump that up, and if I know I'm going to go the full route, let's put her on an onward breather as well, crank that up, and let's get the highest possible sustained SpO2 that we possibly can before we even think about taking her off the oxygen. This is a wonderful opportunity for even basics to get involved, because tolerating a nasal cannula and an onward breather and help to coaching a patient through is of paramount importance when you want to intubate these patients. So I get my basics involved in these specific aspects as well. Then you paralyze your patient, and then you do your very best to intubate them. What do you think, Megan and Virginia?
I think I want to stress again how difficult this patient would be. We looked at the tongue, and that's going to be really difficult to get a ET tube pass. But then also, like, all that stuff in the front of the neck means that all the landmarks for a crike or a surgical airway are gone. And so that means this looks really difficult. And I think I just want to re-stress, like, our options are a little bit difficult in this scenario. Can you talk a little bit about a supraglottic, and maybe that would be the best option here, or what would be the best option? What did y'all do when you received this patient?
This patient wound up needing fiber optic intubation. We had diagnosis pretty quickly, just based on the external findings, and we knew this was going to be very, very difficult. So we went to fiber optic first, and you want to put your best foot forward. We don't have that luxury in the field many times. So to be quite frank, I think if I had put this patient in the back of the box, I would have prepared for an RSI. But if I had any difficulty whatsoever displacing the tongue with my video laryngoscope or even my direct laryngoscope, there would be nothing wrong with putting a supraglottic airway and then throw a king and getting something in there. Remember that it's not, even though there can be some tracheal involvement, it's not within the trachea, it's around the trachea. So you can still get indirect ventilation through your king or your supraglottic airway. So I would have prepared for RSI, but if I encountered any difficulty whatsoever in visualizing, I would have thrown a supraglottic airway in place. We discussed a crike on this patient. As someone who's done both pre-hospital and emergency department care intubations for many years, I can tell you this would not be a crike that I would be very happy about attempting, because it's just so full. There is so much edema. We saw that cross-section of the patient's MRI, and just how much fluid and stuff that was in there. Her landmarks were absolutely nil. So I would have done my very, very best to do an endotracheal tube or a supraglottic airway. You would have had to basically you would have to push me really hard to try do a crike on this patient. Since she was decompensating, I don't blame the medics in the least. Bring her in, and we can use our fiber optics. If you don't have that luxury, you want your best foot, your best operator in place. Of crike is what you need to do, but get prepared for a very bloody, very messy crike. We see results of our poll here. your advanced airways, most of you have RSI, VL as well, Crike, or all of the above. I'm gonna take a look at the chat here very quickly. Here is a comment, commitments in EMT, allergic reaction, tongue swelling. She's increased blood sugar recently, or is the insulin a sliding scale? She's on 70/30. If I remember correctly, she was using it on a sliding scale, and they were tapering off her metformin a little bit. Depending on the swelling, would it be easier to drop a king? Yeah, exactly. I'm right there with you. I think it would have been far easier to through a supraglottic airway if I had any difficulty whatsoever with the ET tube. Megan, any final thoughts on airways?
No, I think that you just need to be proactive when you see the increasing in swelling and, you know, nothing's working, and, you know, you really got to think ahead, or what are my options and what route am I going to go down? You know, I personally like to play worst case scenario. I'd rather be over aggressive than under aggressive and have to play catch up later. So I think that I'm happy with my decision to get the king tube down.
Now, some folks would say, why not a nasotracheal airway? You got any opinions on a nasotracheal for this patient?
You know, I think that the swelling is definitely intimidating, and we do have the nasotracheal option. I think that Virginia had talked about when we spoke yesterday about the how it can irritate the swelling and potentially break open the abscess. You know, if that happens, it's an abscess. It's going to pop at some point, and we want it to pop and drain. I'd rather have a popped abscess than no airway. So if you are comfortable doing that, or if that's your only option, then I would say go for it. You got to have that airway.
I think this would be definitely nothing wrong with it. I think the patient was awake enough that you would have probably had to do some ketamine in the field for her to tolerate this even better, because I've never been nasotracheally intubated. I don't want to be. This would be a very uncomfortable position, procedure for somebody with this habitus, with that amount of swelling, but definitely an option. Let me address some of the comments while we're wrapping up, and keep your comments coming. Nasal intubation will be a bloody mess, and this patient will fight you like a wildcat. You're absolutely right. Yeah, you would definitely have to use, give me some ketamine or your highest dose of midazolam that you possibly can. Load me up with some fentanyl if you have to. But I think a supraglottic airway might do the trick. Worst case scenario, you know, a crike. But ultimately, thankfully, this patient did just fine with a fiber optic airway. She did go to the operating room, have a drainage. Her mediastinitis got a lot better with the broad spectrum antibiotics, and she did well. So I would like to thank Megan, Virginia, Paul, and CareerCert, and Danielle especially for the opportunity. If you have any questions or comments, please drop us a note, leave some feedback for us, and we hope to see you again soon. We'll be trying to do this often.
Yes, thank you guys so much for joining us today. We're so glad, and thank you for everyone who attended. We're so glad to be able to have this conversation with you, and we hope to continue it with you in the future. So please reach out to us at any time. Follow us on Facebook or other social media channels to learn about future webinars that we will be holding where you can earn free CE credits. And visit CareerCert.com for other free resources about how you can best protect yourself, your fellow providers, and your patients. Thank you again, everyone, for connecting with us today, and thank you so much to all of our presenters for this wonderful information. Again, we're so grateful for this opportunity to connect with you, and thank you for your sacrifice to make our communities safer places. Stay safe, everyone.
Thank you all.
Thank you.